We had a very invigorating transplant eligible session. We discussed a variety of things. I'd say the main takeaways, number one, was the study comparing BTD to RVD, so bortezomib thalidomide dex to bortezomib lenalidomide dex, suggesting a superiority of RVD over BTD. I think one of the most interesting abstracts was in the CASSIOPEIA study, which was the addition of a monoclonal antibody to VTD as a backbone. We had two abstracts. One of them looked at the addition of the antibody and is it of any benefit in patients with high-risk cytogenetics. And it did seem to show benefit in terms of MRD rates, potentially in terms of other endpoints, which it's a little bit too early yet to see, but this was sort of the first signal that maybe adding that antibody on top of already a proteasome IMiD backbone could be beneficial for high-risk cytogenetics. The third abstract we talked about was on the same study, but looking at assessment of minimal residual disease, which I'm sure you've heard a lot about at this meeting. It asked the question, what's the best method? Is it flow cytometry or is it next-gen sequencing? In that abstract, he did show that 25% of people who were negative by flow cytometry actually were positive for MRD by next-gen sequencing. And that may just be a factor of the sensitivity of their flow panel, but nonetheless, it is something of interest to many of us. And then the last abstract was a much more general registry study. It was very important because it was a worldwide registry. And it looked at how long do patients stay on therapy, why do patients stop therapy? And I found it actually very striking because still the two major reasons patients stop therapy are obviously disease progression, and the other one is toxicity, with neuropathy still being a major factor, in fact the leading reason that people stop therapy.